I'm really excited. So Courtney and Amber and I worked together on this presentation, and I'm excited for them to be giving the majority of it. And then at 2:15, we have a speaker that's going to join, a parent of a child who's going to talk about her journey with a genetic diagnosis and her son's life and death. So yeah, so I'm going to go ahead and start. Hold on a sec, I gotta make you guys a little smaller so I can see the slides too, since I'm here at home with just the one screen today. Okay, so our learning objectives, I always like to start with a little bit of the history of the relationship between genetics and the disability community, and where that historically started and how that relates to genetic counseling specifically, and then where we're at now, because I think it helps to understand that history to see where we're coming from. And then we'll also discuss the relationship between the genetic counseling profession currently and the disability community, some genetic testing methodologies that are being used, and then also, again, some current perspectives of individuals and families. Okay, so one of the reasons that I really like to share some history, and this is going to be pretty brief, but is I was well into my career before I heard a lot of this history. I knew bits and pieces, but how it related specifically to genetic counseling, and it really filled in the gaps for me on, I don't know, why some things are the way they are now. So I like to share it. And one of the things that I did know, but just didn't know much of the details of, was that historically the misperceptions and misinformation of genetics negatively influenced the lives of individuals with disability and their families. And I want to talk about some specifics of that. So in the 1800s, and actually continuing into the 1900s, but beginning in the 1800s, there was a social paranoia that led to a scientifically sanctioned eugenics movement. So eugenics means good genes, technically, but what eugenics is the idea that certain people should be passing on their genes and other people shouldn't. And when I say scientifically sanctioned, meaning there was this idea that, oh, this is a scientifically valid concept, which it is not. It is entirely a socially constructed idea based on prejudices and based on, again, social systems and things like that. And the result was, again, very disastrous for individuals with disabilities, among other people, resulting in segregation and sterilization. And some of those programs continued, again, even much further into the modern era than we would like to admit. And that eugenics and the pseudoscience that supported it, even after it passed out of favor, and people were like, oh, actually, this really isn't based in science. Some of that legacy continued for a really long time. So institutionalization and sterilization for a long time. So there were a number of things that happened, but the 1960s was a time where there was a lot of changes happening both in genetics and in the disability services community. So this sort of disastrous association in the past led these two communities in very different directions. So in the disability community, there was, again, a focus on a community integrative approach and sort of a rejection of genetics. And in genetics, there was really a move towards medicalization. So focusing on those things that were medical conditions and how we could understand those, and really a move away from trying to understand or categorize behavior or intellectual ability, things like that. Really a move towards the medical side to try and distance the field from the eugenics history. And so this sort of divergence led to some differences in the way the two fields looked at things for a long time. For a long time in genetics, we used descriptive dysmorphology, so ways to describe similarities and differences in people that helped give us clues to genetics. And the move towards person-first language was stronger in the disability community, although in genetic counseling, we use person-first language now. The assumed etiology, so when I say etiology, I mean underlying cause. And so in genetics, a lot of people are thinking about what's the genetic cause or other cause of intellectual disability or another disability. And so in genetics, we were mostly focused on genetic causes, and there was, again, less focus on those genetic causes in the disability community. Because of that focus on underlying genetic causes, the idea that understanding the cause at a genetic level was important was really more primary in the genetics field than in the disability world. And so research also focused on different things. So research in genetics focused on similar causes, so chromosome disorders or groups of conditions that are genes that are related, regardless of what the features were for the individuals that had those conditions. Whereas in the disability community, more research focused on understanding people who had different behavioral diagnoses or different, who are at similar levels of function. And a lot of this data actually comes from Brenda Finucane, who is a genetic counselor who worked for the majority of her career at Elwyn, a residential facility for individuals with disabilities, and really was in both worlds. And so what has happened in recent years, thankfully, is a recognition that these are complementary approaches and not independent, and both are important. And so really the two communities have come back together and in lots of different ways tried to sort of broach those differences that were there in the past and see the value of those both perspectives. And really that's where genetic counseling as a field developed in the, there's a slide on this and it coming up, but really as an official field with specific training in the late 70s. And as a way to bridge the gap for families between the medical, the social, the psychosocial. So we're sort of at the intersection of those things. One thing that is, this is 10 years old now, but still feels like recent history, is that the American Association of Intellectual and Developmental Disabilities Manual put out information about what might be some of the benefits for individuals and families of understanding etiology, so that understanding that underlying cause, whether it's genetic or not genetic. And some of those are listed here. So our understanding that gene changes can cause lots of different associations. So we, in addition to a person's disability, there may also be health-related problems that could be anticipated and minimized. That there are some conditions that are treatable, especially metabolic conditions. That understanding that there are common strengths and weaknesses based on specific gene changes can help us with specific behavioral interventions that might be helpful. That it provides information that facilitates understanding who else in a family might be impacted by a condition. And one of the things that's come up more recently that families have found benefit in is using that information to connect to other people with similar experiences and similar etiologies, so that there can be support and information sharing and experience sharing. And for some people, not everyone, some people don't find it helpful to know an underlying cause, but for some people, having that information is really empowering and helpful. And so at this point, I'm going to hand it over to Amber and Courtney to talk about genetic counseling specifically and what our role is.
Awesome. Thank you, Carrie. Yeah, so I wanted to just start off by kind of expanding on what Carrie just talked about by getting more specifically into how genetic counselors fit into the disability community today. And some of this will be a little bit of review from things that Amber and I shared in our first presentation last fall, but we hope to kind of dive a little bit deeper. Go ahead, Carrie. So to start off, the National Society of Genetic Counselors, which is kind of like our governing organization, they published a definition of genetic counseling. And it reads as follows. So genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. And this process integrates three main parts: interpretation of family and medical histories to assess the chance of disease occurrence and reoccurrence, education about inheritance, testing, management, prevention, resources, and research, as well as counseling to promote informed choices and adaptation to the risk or condition. So those are things that we've kind of talked about before, but we definitely want to jump into each of those a bit more during this presentation. And Carrie, you can go to the next slide. Oh, did you skip one?
I think I did. Hold on.
There you go. So genetic counseling as a profession is based on three core principles or tenets. So those are, the first two are very similar. So a non-directive approach, as well as autonomy and patient-directed care. These are pulled from the field of psychology. So some of you are probably pretty familiar. But for us, that means really allowing the client to lead the session and have control over their decision. So we don't want to push our own personal opinions or decisions that we would make in our personal lives, but rather facilitate their own decision making. And then again, unconditional positive regard is also from the field of psychology. And for this one, it refers more to the idea that we respect our clients regardless of their opinions or decisions, and trust that they are able to make decisions that are best for them, especially even if it's not the choice that you would make yourself. We'll continue to provide support and empathy and acceptance. So for me, I'm not necessarily in a session thinking, am I providing autonomy and unconditional positive regard? But overall, making sure that I provide my clients with all the information that they would need to make a decision that is most appropriate for them, their family, their life, and really just empower them and advocate for them if necessary. Go ahead, Carrie. All right. So as Carrie began to mention, genetic counseling is a fairly new field, especially in comparison to some of the other medical and psychology fields that we talk about. So the term genetic counseling was originally coined in 1947. However, it wasn't necessarily recognized as a clinical service, and it definitely wasn't part of the medical field like it is today. But in 1969, the first genetic counseling training program was established at Sarah Lawrence, and that was a master's program, so just as it is today. In 1979, the National Society of Genetic Counselors was founded. That's that organization that we talk about a lot. And then in 1982, the University of Cincinnati Genetic Counseling Graduate Program was established, which is what the three of us are a part of. And it's one of the oldest genetic counseling training programs, which is pretty cool. So as of now, the most recent kind of numbers just published in 2021, there were 5,629 certified genetic counselors in the US, which we're still a small field because we are fairly new. And I just looked the other day, and there are currently 56 accredited graduate programs between the US and Canada. That has been growing exponentially. And our NSGC Society has posted that they believe in 2030, there's expected to be more than 10,000 certified genetic counselors in the country. So that's really exciting because although we are new, you can clearly see the growth that's expected. And then this is a slide that I think we shared with you last fall. So just to review kind of in general, the different roles and specialties that you can find genetic counselors. So everything from cardiology, cancer, prenatal, pediatric, neurogenetics, certain specialty clinics like metabolic, testing labs, even adults outside of the cancer field. And we can do these roles at different institutions. So of course, universities and hospitals, but we can also work for labs, insurance companies, as well as nonprofits and government. And so for the focus of our presentation, we'll stick with kind of the pediatric, general, as well as neurodevelopmental specialties. So in talking about pediatric genetics, oftentimes we work as a team with a genetic doctor, a geneticist, okay? And a lot of times our roles are split up so that we each have kind of our own focus with a client. However, it definitely depends on kind of where you work and who you work with. But in general, the geneticist would be responsible for the physical exam. So we don't do any of the physical exams or do anything where we would need to kind of touch the patient. They would help create a list of differentials, which would be like similar things that we need to make sure to rule out when we're going to diagnose a condition. They would possibly be responsible for ordering testing and establishing a diagnosis if there's one available that we find. They would be responsible for kind of deciding what treatment or management would be appropriate. And then if it's medication or referrals to other specialties, they would do that. For our job, we have some overlap, but we would typically start out with the intake. So collecting information on medical and family history. We would draw out our pedigree or the family trees like Amber and I showed you last semester. We would also help create that differential diagnosis list. And then we would help explain all the different testing options. So a lot of times, maybe the geneticist has one that's ideal in mind, but we would want to make sure that they understand what those options are and also understand if they're not necessary, because a lot of times genetic testing is optional. And then we can possibly order that. We would also help to explain the diagnosis and any of the kind of etiology like Carrie was talking about, as well as things like inheritance and recurrence risk. And we would also help explain in kind of patient-friendly terms the treatment and management options that are available. And all throughout our appointments, we make sure to provide psychosocial counseling whenever that should be necessary or appropriate, and help facilitate that decision-making process for them. We typically handle case management and advocacy just as appropriate. So, we might stay in touch and act as a liaison for these patients kind of throughout their care. Okay, so this is a study that Carrie has shared with our genetic counseling class a few times, I think, and I think it's really it shows the importance of teamwork for sure. So what we're looking at is a study that compared 100 pediatric patients who saw a genetic counselor along with a doctor. So that's the lighter gray diamonds. And they compared that to 100 pediatric patients who just saw a doctor. And what you're seeing here on the graph is their adherence to the recommendations in a couple different settings. So after they saw them the first time, did they do the necessary follow-up? Did they see the referred, the specialist that they were referred to? Did they follow through on whatever testing was decided? And what you can see here is that in the patients who saw the team, the genetic counselor, along with the geneticist, there was higher adherence rates. And so this goes to show that kind of the teamwork and the interdisciplinary care can be really beneficial and impactful for our patients.
So I'm just going to go a little bit deeper into things, some of the roles and that genetic counselors take on. And since this is LEND and we talk a lot about neurodiversity and those kinds of situations where you may encounter those individuals, I wanted to talk a little bit about where we interact with patients who have an intellectual disability. And one of those places is in just a regular clinical genetics setting. So there are clinics that patients can go to specifically for a genetic condition. So some of those that may cause intellectual disability are Down syndrome, Fragile X syndrome, Turner syndrome, Cornelia de Lange, Rett syndrome, Crutchlow syndrome. Some of these may be familiar, some are more common than others, but we would see all of those. Jason, did you have a question?
Yeah, it was just because with the term neurodiversity, so like, does that also include like mental health or other things, or is that because it's not a genetic, they're thinking a genetic cause? And then, sorry, I just was making sure because neurodiversity and the neurodivergent is a sort of all in cut, like it's a blanket term
A broad term, yeah.
that goes into intellectual disability and developmental disability as two different terms, and then other sort of things around it. Sorry.
Yeah, there's a wide range, which is why I wanted to just like use a broad term, because I don't want to ever say like we only see people with one specific kind of disability or whatever, because some of these conditions will cause severe intellectual disability, and then some there might just be like developmental delay, and that's caused some learning disability or things like that. But we do tend to focus on seeing patients where there's a genetic cause to what's going on, rather than a mental health cause. Carrie, did you want to add something?
Yeah, I was just going to add that there are psychiatric genetics clinics across the country that focus on helping individuals understand the relationship between genetics, environment, and mental health. There's not a ton of testing to do, which is okay. It's more about explaining and helping people understand and helping them understand how things might run in families. And there's actually just recently a geneticist who's spending part of her time in psychiatry doing a number of different things. But there's so few genetic counselors that there's lots of areas that could have more access to services of genetic counselors. And that's probably one of them. Good question.
Yeah. And then we also will see patients in certain specialty clinics. So where there's a lot of providers all seeing the patient and kind of inputting their recommendations. Some of those clinics that exist at Cincinnati Children's are neuromuscular clinics, tuberous sclerosis, epigenetic syndromes, metabolic conditions, neurometabolic syndromes, rhasopathies clinics. These are all separate clinics where there'll be multiple doctors of different specialties who will evaluate the patient, and a genetic counselor is often a part of that consultation process. And then in prenatal and cancer clinics, we don't talk about those a whole lot here in Lend, but we also may see patients who are pregnant or want to have a baby, or who maybe have a family history of cancer, who also have their own diagnosis of an intellectual disability or a different genetic condition. And so we may run into those individuals in that setting as well. And then Courtney mentioned that we also are involved in advocacy work as genetic counselors, and may be involved in different support groups for a rare genetic disease. And often GCs are also involved in policy and advocating for individuals with a genetic condition, or for various kinds of testing or things like that. So those are all places where you might find a genetic counselor working.
So I have
And
a
then,
sorry. I
yeah.
was just curious with some of those things, because I think you could see a lot of different things that sometimes have genetic components, and some of the things about like mapping some of the genomes. It seems like with the ones that were on the first things, they were sort of more like maybe the way that it goes within that, at least the first part you're talking about, and it's sort of ones where they know it's sort of a simple, like where it's not as complex genetic makeup of multi-factors. Not that it's not simple either, but if that makes sense. Sorry, I'm not trying to, and I could be completely wrong because this is not my area. I'm just trying to understand.
Yeah, so I listed under the first section specific conditions. So like a name like Down syndrome or Cornelia de Lange are like specific syndromes. And so those are all syndromes where you're right, we can point to like, it's this one gene or this chromosome or this area where there's a problem. And then on the specialty side of things, I just listed more broadly, like these are the types of conditions that we might see patients for. And then within each of those categories, there's a whole list of specific conditions, just like I listed out on the first section. Was that what you were kind of getting at?
Yeah, I was sorry. I was just trying to understand like how you sort of do different genetics things, just because some of the genetics talks go into a lot of, especially right now with the autistic community, some of the things about how much genes are collecting and what that sort of is being used for and how that's been used in the past, or organization that supposedly doing advocacy or doing stuff. So I was just thinking, sorry, connecting a lot of weird things, but also not knowing enough to make sure that I'm not like just saying things. Sorry about that.
Yeah,
I think
no.
you're entirely correct that traditionally genetic counselors have been most involved in things where the genetic explanation was very clear and more straightforward, although the more we learn, the more things are complex, as you said. And it has been more in more recent years where we've expanded our roles into working with individuals who have more conditions with more complex genetic components. So you're exactly right.
Yeah, thanks for your comments, Jason. Other places where you can find genetic counselors, Courtney touched on this, but different management roles within a clinic setting, within a hospital, or in a startup company, genetic testing companies, places like that. GCs will often be managing a team of genetic counselors or a research team, things like that. In the laboratory, often when we say that word, people think about like this picture here where you've got vials of liquids and microscopes and whatever. And typically a genetic counselor's role in a laboratory is not going to be that. We don't usually work with liquid and experiments and chemistry type stuff. More often the role is we are looking at a genetic test report and doing things like variant interpretation. So helping to decide whether a certain change that was found in somebody's genetic testing report is actually going to be harmful or not. Or there being a point person for the doctor who receives, a genetic test report from the lab and they have a question about it, they can call the lab and the genetic counselor will help answer their question. So more things like that. Yeah, Pat?
Actually, I have a question. And I asked this, I think, when you all did your first presentation. Do you all address, or is there any current research that's looking at, because I'm assuming that with genetics and genetic counseling, some of the chronic illnesses or some of the secondary chronic illnesses resulting are either from where, for some unknown reason, the chromosomes split as they do, and then this develops, or because it's passed down from a familial perspective. But the question I raised then, and this is raising it again, is there any research or do GCs approach this or look at this from the perspective of, first of all, the number of men who are having babies by multiple women and are producing then half siblings, and then those half siblings not knowing each other are then meeting one another, I'll put it that way. And then, let's see. Oh, then other thing with the use of modern technology and the use of sperm banks. And so the sperm banks are then being used for multiple women. Sometimes hundreds of women are able to use those sperm, and those become half siblings. And so is there any, I guess the question is, number one, is there any research that looks at or has addressed or is in the process of addressing how that will impact some of the diagnoses we've seen with genetic counseling? And because then you've got the familial piece along with the potential environmental piece, both of them. And are there any primary prevention focuses that are taking place to educate the community about this potential link or connection with some of the genetic disorders that may exist today? I know that's two loaded questions, but.
So I will answer with the first thing that comes to my mind, and then I'll have Carrie give probably a much better, more comprehensive answer for you. But as far as, you know, the chance of being related to somebody and then having kids together and having health problems, the genetics community is very aware of that as a potential cause for certain genetic conditions, and genetic counselors are very aware of that. And one of the things that we learn about different conditions is like, what's the, you know, carrier frequency of this, and how many people are carrying a mutation that they don't know about. And then maybe when they go to have a kid, you know, that shows up in their child if their partner is carrying the same mutation. So we do learn about that, and we're made aware of some of the big conditions that are maybe passed down that way and are unknown in families for a long time. And as far as like what we can do about it, the most tangible thing that we have right now is something called carrier screening, which I'm not sure if we brought up the last time we talked. So if we did, I apologize, but I'll just do a quick explanation of it again for you. So basically, when a pregnant mom or a couple who wants to have a baby and, you know, they just want to know what risks they might be at for a genetic condition for their kiddo, they can come see a genetic counselor. We can do a blood test on mom and dad, on both of the individuals, and look and see if they are carrying any of the mutations that would cause one of these conditions in the families that could come out in birth. So cystic fibrosis is what we use most common as an example. So a lot of people are carriers for cystic fibrosis. We can test and see if you are a carrier, and then if they are, we can test the partner. If they're a carrier too, we know their child's at risk. So if we suspect that maybe there is some kind of relation between the two parents, or if they just don't know their history and are curious, we can offer that as a way to screen and see if their children might be at risk for any of kind of a broad range. There's over 200 conditions we can test for that way. So that's one answer. Carrie, do you have anything you want to add to that?
Yeah, what I'll add is that the situations that you're talking about are still rare, where individuals are more related than they expect, but it does happen. The risk of having a child with a genetic condition is increased, but it's not as high as most people think. Carrier screening can pick up some of that, but it's going to miss a lot of things. One of the ways that that information sometimes comes to light is if a child does have a genetic condition and they get a specific type of test that Courtney and Amber are going to talk about later, called a microarray. A microarray very specifically can identify if the parents are more related than they realize, or are related by blood, because there'll be large areas that are very similar. So sometimes that gets picked up incidentally and not what we're looking for, but we find that and we can talk to families about that. So I don't know if that completely answers your question. I'm not as familiar with that literature to be able to give you exact numbers on frequency and things like that, but some of that does exist.
Yeah, actually, I think it might be more frequent than you think. But the other piece was in the primary prevention part, because I don't remember hearing any kind of community public education that talks or addresses this. And I'm not sure if it's because as a society we're not ready to deal with it, but it is real. And so that's why I was just wondering, do GCs or does the field of genetics see themselves as conducting research in this area and then taking on the role of educating the community from a primary prevention before it happens and not after? Yeah,
it's not something that I know of big initiatives to address. It doesn't mean there aren't GCs that are doing it, but it's not something that I know
about. Carrie, you can move on to the next slide. I think we'll just keep going. Hang on, I see Jason put something in the chat. We regarding kind of working with individual patients versus like a population, thinking more in population terms, we definitely will focus more on the individual patient in most settings where you find a genetic counselor, but in places like advocacy or policy work, or maybe certain nonprofits where genetic counselors work, they may be thinking more of the population as a whole rather than providing care for an individual patient.
Like, what would that mean? Because would that be more for like more genetic testing across the board, like to do like a genome collection sort of thing, or like
just thinking about ways that we can provide care better for people in a general term versus having there be like a one patient in front of you and you're deciding what's the best thing to do for this particular person and then carrying that out, versus someone in policy might be thinking like, we really want to decrease breast cancer, and how can we put in policies or how can we advocate for testing to do that as a whole for the general population. So just kind of switch it back and forth in that way.
Oh, okay. So I mean, yeah, sorry, because it's just I'm thinking of some of the, and it might be addressed later, but I just want to make sure I understand the framework, so I'm not saying things. I'm sorry I keep going at this, but I just want to make sure.
No, you're good. We want to help you guys understand whatever questions you have, so that's totally fine. I'm not going to go too into depth because Courtney kind of talked through this, but clinical responsibility. So when we have a patient sitting in front of us, we're going to start by contracting, which is the word we use for just kind of building rapport with the patient, finding out what it is that they want to get out of the session, finding out what their concerns are, and kind of building the rest of the session around those concerns and questions. We'll do the intake like Courtney went over, do a risk assessment for them, kind of explain maybe the likelihood that they have a genetic condition or their child does, or that genetic testing would help them. Depending on what the situation is, that discussion changes a little bit. We'll talk about what genetic testing is and how it's performed and answer any questions they may have about that. And through the whole appointment, we're kind of doing an assessment of them and making sure that they're okay, checking in with them to see if the information is overwhelming or how they're responding to that. We will kind of follow their case through to completion. So when we get those test results, we'll give the results back to the patient, make sure that any doctors know about them that need to know about those results, that kind of thing. And just kind of facilitate getting whatever that patient wants done. Genetic testing is never something that a patient has to do. So we want to make sure that the patient has enough information about the test and how it could help them before they make their decision of whether they want to go through with it or not, since we don't sit there and say, this is what, this is the next step, so let's just do it. They get to decide if they want to do it or not. So I just wanted to pause on the risk assessment piece for a little bit. This part can be interesting because we all have a different idea of what risk means, and we all have a different idea of what we are at risk for or not at risk for and what that looks like. So you can go to the next slide, Carrie. We have a little activity here that we'll just go pretty quickly through. Oh, I forgot we have one more slide first. So just talking about risk, like I kind of alluded to previously, the individual's perception of their risk is often more important than the actual risk they have. So somebody may come into an appointment and think they're at a really high risk for a certain genetic condition or for cancer or for something like that. And we kind of have to figure out, why do they feel like they're at a high risk for that, and walk them through how do we get your actual risk number. So we will spend time doing that as a genetic counselor. And people's beliefs about their own personal risk can be influenced by a lot of different things. It can be their understanding of what that risk actually is, previous experience with that condition, beliefs about whether they think that thing is going to be good or bad for them. And then also kind of how recently they've heard about different things or what stories they've been told, and then how it's framed or communicated to them can also make a difference. So you can go to the next slide, and then we'll do our little activity. So these are all statements about different genetic things that might happen, and we have words underlined here. So I'm going to read through each one of these and type in the chat or write down on a piece of paper or take note of what you think that means. So for example, the first one, your child with NF1, which is a genetic condition, has a high chance of having a learning disability. So is high mean like 80%, 60%, 95%? Just put in the chat or in your mind a number for that first one. And I'm just going to move right along on these, and you guys can keep notes. For number 2, the chance an individual with Marfan syndrome will have an enlarged aorta is considerable. What would you say for that considerable? We got lots of numbers coming in, so thanks, guys. Okay. 3, your lifetime risk to develop diabetes is moderate. What does moderate feel like? Some of these are pediatricians and doctors in this group may know the actual numbers of. Okay, 4, cleft lip is a common birth defect. Whatever common means, that could be like 1 in 100, 1 in 500 births, something like that. 5, a woman of 35 has an increased chance of having a baby with Down syndrome. And 6, Morquio syndrome is a rare genetic disorder. Think about what you think rare might be. Okay, and you can go to the next slide, Carrie. We'll just keep moving along. I know you guys are still typing in. Thanks for participating. So these are numbers. These are average numbers. Don't use this slide as a reference for these risks, but these are just some numbers here. So you can kind of compare and see if you were along the right track or had kind of a wildly different idea of what some of those numbers mean. But even just from seeing everyone's numbers in the chat, we were all kind of a little all over the place on some of these. And so you can get the idea that someone might hear from a doctor, oh, you have a high risk of having a child with Down syndrome. And, you know, to them, that means, well, there's a 95% chance then, or something like that, when that's not really true. So we like to kind of clear this up with patients and make sure that they understand what their risk might be for certain genetic conditions. Yeah, Jason?
Question. Yeah, because I know this is some of the other things that the disability movement sort of critiques in some ways, is not necessarily the numbers of those things or how much, but like especially with the learning disability and the one with women having Down syndrome, because of some of the ways like we sometimes think, oh, that's terrible, like there's going to be a learning disability, rather than there's so many different types of learning disabilities and ways. Or even with Down syndrome, you do have countries that with anything of the Down syndrome being that because of maybe some of the ways that it's talked about or some of the things about it, and I'm not saying everybody, but you know, there's sometimes more of a push to, you know, because there's this thing that this child won't have any quality of life. I don't know if that's changed over some of that, but I know there's some of the ethical concerns of like, even if we're saying that somebody has a child with Down syndrome, does that mean, and not saying that women still shouldn't have the choice or that it shouldn't, but sometimes it seems like we've had some of those older sort of biases also of what does this actually mean for somebody if they're
and we it's a good point that you bring up, because that's been definitely been something that's been debated a lot about, and like, should we even be doing testing for some of these conditions, and how helpful is that, and how should that information be used? And one of the things that I will say, at least currently in the field, we spend a lot of time talking about how do we best present this information to parents. And in the case of like a prenatal setting where we're talking to a mom and giving her risks for different genetic conditions, in my prenatal rotation that I did, we had, you know, we spent a couple minutes talking about how, you know, this test looks for your risk of having a child with Down syndrome. And then we'd say, you know, if they don't know what Down syndrome is, or ask them what their experience is, and then, talk about all the wonderful things that children with Down syndrome experience in their lifetime and what great blessings they can be. So we definitely try to make sure that parents know, we don't see this as saying, your child's life is any less valuable for having this condition, but we do have it as an option to look for. And so we want to offer that option to families. And a lot of families appreciate having the chance to prepare for a child who's going to have a significant genetic diagnosis or condition, even if, they're not considering termination or anything like that. So yeah, we do try. And I know there's definitely still room to grow for sure in our relationship with the disability community and finding out how they want us to talk about certain conditions and things like that. But I think that's part of why things like LEND and stuff like that are so helpful for us. So
thank you. I appreciate that. Just because I know there can be some nuance, or even sometimes with learning disabilities, it's like, oh my God, it's a disability. That means they're never going to be able to do, or they're not going to have a functional being able to.
I can say my experience, I haven't seen providers speak that way to patients or talk about disability in that way at this point.
That's good. I've had some experience with the testing, but it's good to see that things are shifting, and not that it ignores that there might be some things that come up either, because I don't think we want to be realistic, but realistic goes into understanding the two, that it's not one way or the other exactly. Sorry, I don't mean to, sorry.
Yep. Nope, you bring up good points, Jason. And Carrie, you can go ahead and move forward. And I think Courtney is going to walk through some testing, different types of testing now.
All right, you can actually go to the next slide and we'll get into just a really brief review. I know we've been over this, but I like to make sure everybody's on the same page. So just remember, our body is made up of a ton of cells, and in each cell we have our DNA, which is our genetic information. And our DNA is like an instruction manual that tells our body what to make and how to work. And in order to fit all of that DNA into our teeny tiny cells, it needs to wrap up into structures called chromosomes. So that's kind of that X-shaped structure you see there. If you were to unwind the chromosomes, you would see the DNA in that double helix structure that you may be familiar with. And if you were to look even more detailed at that, you would see that along our DNA, we have genes. Our genes are made up of letters. That's how we think of it. So A, T, G, and C. And the sequence of those letters end up making a protein that our body needs to function. Okay, so we're going to talk about some tests. So it's kind of, I just wanted to make sure that we're all on the same page first. Go ahead, Carrie. All right, so this is one that we did mention before, and it's called a karyotype or a chromosome analysis. This is a really big picture test, and it's just as a reminder, we all typically have 46 chromosomes, and typically you'd get, there's 23 pairs, so you'd get one from each pair from each parent. And then the karyotype can produce this picture of our chromosomes to see if there's any difference in structure or amounts that we would maybe not expect. So for example, in the second picture over here, you can see an example of Down syndrome. And we know this is a case of Down syndrome because there is an extra 21st chromosome. So that's kind of a big example of karyotype, but we could also see smaller areas that are missing or extra, or even a piece of one chromosome swapped onto another chromosome with this. Okay, you can go ahead, Carrie. So this is another test that I don't think we've talked about in this class. It's called FISH, or fluorescent in situ hybridization. And this one gives us some similar information to karyotypes. But it can be a little bit more detailed. So what you're seeing here is we have our fluorescent probes that are created for a particular region of DNA. So for example, in this case, we're actually interested in a region on chromosome 22, the longer arm of the chromosome, because that's associated with a genetic condition called 22q deletion or DeGeorge syndrome. And so what you can see is that we've created these probes, and again, we have 2 copies of each chromosome, so that's why we have 2 chromosomes that we're looking at. So you see all 4 probes on the left, and then on the right, you only see 3 probes that are fluorescing. So what that's showing is that on one of those 22nd chromosomes, there is a piece missing. So that would be a deletion, okay? Oftentimes, these are great starts, these big picture tests, but sometimes we need a little bit more of the details to kind of give the best information to our patients. So you can go to the next slide, Carrie. All right, so we're going to talk about a microarray, and we did bring this up in regards to Pat's question as well. So we could easily have an entire hour lecture on microarray, and Amber and I have, so it's going to be really brief, and it could easily be very technical. So in general, there are probes designed for many, many, many locations all across the DNA. So individual locations all across the DNA. And the information that we can get from this is, one, the genotype. So a genotype refers to the allele on each copy. So if our DNA has 2 copies, we can either have the same allele on each, or we can have a different allele on each, okay? We can also get a copy number, which is just what it sounds like, the number of copies that we have. So like we said, we would expect 2 copies for each, but sometimes we could have areas that are missing a copy or have an extra copy. And so that's the type of information that we can get from a microarray. And then the next slide shows what a result could look like. So again, very complicated, but typically the white region that you can see on the right-hand side of the screen is what we would expect a normal result to look like. The orange highlighted region is actually a deletion. So if you're looking at this, the top bar shows us that we only have 1 type of allele. And then on the bottom, you can see that that line is actually lower than the normal reference or the normal region. And so that's showing us that we're actually missing a copy. So this would be a deletion. And we already said that karyotypes and fish can pick up deletions, but this time we can pick up even smaller areas that are deleted and actually identify the exact break point. So you can see where the orange meets the white, that's the exact area where that deletion starts and stops. And that can be really important when trying to explain a genetic condition to someone or a diagnosis, because where that happens and what gene it includes or excludes can really make an impact on our patient. So just at the bottom, it's showing where that would actually be along the chromosome, and then you could do further analysis looking at where that happens. And really quick, just to kind of reference Pat's earlier question, this is also the test that could pick up what we call regions of homozygosity. So homozygosity means that both copies would be the same. And if we all have some areas of our DNA that have the same copies. If we have really long regions, more than we would expect, that could actually be due to consanguinity, which is where both sides of the family have a common ancestor, or it could be for some other reasons, but this is the type of test that you could possibly have that come up in a clinical situation, and that just came up for me last week, actually. So you're right, it does happen. I think we're good on that. Okay. All right, we also have gene sequencing, which again, I believe we've mentioned to this cohort before, but just to kind of show you what that looks like. So this is a much more zoomed in test than the test that we were just talking about. So now we have a specific gene that we're interested in, and we want to actually look at those letters. So just like a book, you need the letters to be in the correct order, in the correct location in order to read the story properly. You need your letters to be in the correct order and location to make the correct protein, okay? So on the top here, what we have is a reference sequence. Each of these colors corresponds to a letter. So these would be, again, like fluorescent probes in the lab. And then you can see, depending on the color, that corresponds to the letter at that location. So the starred location here is red, that's an A. But if you look at the sample, so pretending this is a patient sample, you actually have a T at the starred location at the bottom. From there, you would need to do some further research to see if this small change actually causes any disease or not, because we all do have small single letter changes all throughout our DNA. Not everything causes a disease. Sometimes it just makes us different or unique. All right. Okay, I know that was a lot of technical information, but for the sake of time, we clearly just have a lot of options to go through when it comes to testing, and there are a lot of pros and cons of each. Unfortunately, we have some algorithms that we can refer to for certain indications. So specifically talking about neurodevelopmental indications, we would often start with a microarray. And we would do that because it does have a 10 to 15% diagnostic yield, which is pretty good when it comes to genetic testing. And so what that means is in 10 to 15% of the time for cases where there might be developmental delay or autism spectrum disorder, it would pick up an answer for that. If that is negative, this algorithm is showing us that we could then reflex to Fragile X testing. And I know we've talked about that in this class, but that's a fairly common condition. And then if that were also negative, I will say this is changing a little bit in the past couple, or in the recent years with the gene sequencing technology that we have now. But typically, if there's a girl, you could continue to test for Rett syndrome. And if it's an individual with macrocephaly or an abnormally kind of larger head size, then we could test for a certain genetic condition caused P10. Jason, do you have a question?
Yeah, I'm just curious what that is and why it's still used, because I know at some point phrenology was one of the things about measuring head size to be able to tell intelligence or different characteristics of a person that was part of some of that pseudoscience. So I'm curious in that case, and it could be completely different, why that still is a measure that's used, if it's used differently, or sorry.
Yeah, no, that's a good question. I see how that's confusing. We're not talking about like the head size in this case as anything to do with their intelligence or IQ level. There just is a genetic condition called P10 syndrome or Cowden syndrome that one of the presenting signs is macrocephaly. So when the head is larger than average, and that would just be a potential indication that maybe we should test for this gene. That's kind of when we needed to be more specific, but as genetic testing has become more efficient and cost effective or less costly, we're able to kind of expand that and not need to look for such specific indications anymore. So actually, if we do go to the next slide, we can talk about why we don't have to do that. So we have now multi-gene panels. So this panel, instead of saying, okay, we need to look for the next best gene to test, which might be P10, instead we can use this multi-gene panel, which includes testing, sequencing for many genes related to overlapping conditions. So there could be a panel related to neurodevelopmental conditions so that we don't have to analyze kind of head size for that or anything really specific. This uses that newer technology that is faster and cheaper, like I said. It can include entire parts of genes or critical regions. And then there are methods to further confirm as well. And depending on the lab, each test, each panel is different. So they include different genes. So it's really important to us that we actually pay attention to where we are ordering these tests from. And genes have different clinical utility. So sometimes we might get an answer for a patient that could help get them into a certain research trial that they were hoping for or guide medical management. However, sometimes maybe we get information just on recurrence risk, inheritance, or we just get an answer for a family, and that's kind of all that comes of it. Go ahead, Carrie. So specifically regarding autism and developmental disability panels, there are a lot to choose from. So I was recently reading a paper that was published this year, and they were actually looking at all of the panels that are commercially available. And it seems that it can range from about 50 genes all the way to over 2,000 genes that are associated with these kind of neurodevelopmental conditions. And the diagnostic yields can range anywhere from 2% to about 10%. And of course, as you have more genes included, your yield is likely gonna increase to that nearly 10% range. And in the past couple months, our hospital has actually established their own gene panel, so we don't have to send out to a different commercial lab. We can do it in-house. And this test you can also order along with parent samples, which we'll kind of talk about in a second. Go ahead, Carrie. Okay. So kind of the largest test that we can offer at this point is whole exome sequencing, which specifically looks at the protein coding regions of our DNA. So our whole DNA is not made up of gene after gene after gene that makes proteins. There's only about 1 to 3% of our DNA that is this protein coding regions. And the importance about this is that it contains about 85% of the known disease-causing variants. And it is kind of the best understood parts of our DNA. So exome sequencing was not always so readily available and affordable, but now it is more commonly used, and it can even be used as a first-tier option in some indications, and also for research studies as well. The thing about whole exome is that it's non-specific. So it's not like the gene panel or specific one single gene sequencing that you know is associated with a condition. This time we're looking at genes that could be associated with your condition or not. So it generates a huge amount of data. And I know Risha was putting in the chat that her daughter is kind of undergoing some genetic testing for autism through our healthcare system. And I would guess that it's through the CCHMC panel. And one of the reasons that it takes so long, unfortunately, is the amount of data that you get from this. We all have variations all throughout our DNA. And so the lab needs to go through all of those to pick out what could be relevant and what is not relevant. And so one way to help that is to have the trios or the parent samples as well. We can use those as a reference to help clarify some of the uncertain results. But then the lab also has to kind of go through and compare to parent samples. So again, that's why it can be kind of take a lot of time at this point. And like I said, the goal is really to determine which variants are related and which probably aren't. Each single lab has its own kind of process to this, but the goal is to really just filter them out and prioritize. And so they would, you can go ahead, Carrie, it's fine. So basically they would remove any variants that they know are really common in the general population and or are benign or not disease causing. Or just in areas that they're not concerned about having any relation to the presentations in your patient. They do want to keep variants that are really rare or not seen in the general population very much. Things that are likely to have a big impact on the actual protein that's made, or maybe it's not even made at all with a certain change. And then they also want to look at family history and compare to kind of the inheritance patterns that would make sense within that family. So once they have this kind of automatic filtering, they can then narrow it down even more and review them manually.
So some possible results that could be, oh yeah, Carrie.
I'm going to jump in here just given time and just hit a couple points and wrap things up if that's okay, because I want to make sure we have plenty of time for the speaker. Sorry to interrupt you. And these slides Courtney sent to Stephanie, so they'll be on Canvas so that you can look through some of the other stuff, but I just wanted to hit a couple things. As Amber was about to say, there's actually lots of different results of different levels of certainty that we can get with this test. And so I'm going to skip that and that. So we get a lot of information, but sometimes a lot of information is good, and sometimes a lot of information is too much and too much uncertainty. And so there is a lot that needs to go into talking to families about whether they want these kinds of tests and what possible results they might get. And then there's some slides in here that talk about parents' perspectives. There's been a number of studies done on what the experience was like for parents whose children were having whole exome sequencing. And we're not going to have time to go through all of those, but I recommend looking through them. And I think it's similar to other types of evaluation that parents have, hopes of finding an answer, but don't always expect to. One of the things with exome is sometimes we find information that is not the information we were looking for, and some people appreciate that, and some people don't want that information. And that even if the information is uncertain, people may want to ascribe a lot of meaning to those results. So I'm going to skip these, but definitely take a look at them. And if you have any questions, feel free to email Amber or Courtney or myself about them. And there's this video here that we're not going to watch, but I recommend if something that interests you. This was put out by Matthew Might, who is a parent of a child with a specific genetic condition. And he talks about their experience going through a diagnostic journey. And then he, once his son received a diagnosis through an exome sequence, actually he had 2 of them, it's a long story, but he then used the internet to try and connect to other families who had the same change, because it was a change that really hadn't been reported before, and was able to build a community and find other people. And that allowed more research to be done on that condition that would have been done otherwise. And he's written a lot about how do we create these structures of working together between clinical genetics research and families and parents and individuals to try and use the strengths of all of those different groups to, he worked in IT and very specifically could design a blog post to go viral. And he's worked now on trying to create infrastructure to allow people who don't have the resources or the expertise to try and create those communities. So we're not going to watch it, but I recommend either reading the New Yorker article or watching his video. It's really great. And there's a quote from him in here as well. So at this point, I'm going to stop sharing. I'm going to have everybody take just a couple-minute break, and we'll get things set up for our next speaker to share. Let's say 2:23, 5 minutes. Thanks. Leslie, I think you're here, right?
Yes, I am.
Hi, thank you for being here.
Of course.
Are you able to share? You have slides, correct?
I do.
Yeah, are you able to
if you
share?
don't mind, I can share my screen.
Yeah, that'd be great.
Okay. Is that working for you?
Yep,
Great.
yep, we can see them. And I just wanted to give people a few minutes so they can take a bio break before you get
Of course.
started. Yeah. All right, hopefully people are starting to come back. And I'd like to introduce Leslie Rohr. And Leslie, I'm going to let you tell everyone about yourself and just let you jump right in.
Okay, thank you, Carrie. As Carrie mentioned, my name is Leslie, and I am going to take a bit of time to share our story about our son, Benjamin Rohr, with his diagnosis, his life, and eventually his death. I'll just get started. When we sought out to start trying for our first child, my husband and I went through the preconception meetings. We did the preconception genetic screening, and everything came back normal. We had a very normal, healthy pregnancy. Labor and birth were very uncomplicated, very straightforward. Benjamin was born. He was very tiny with a beautiful full head of hair, and breastfed really well past all of his newborn screening. And we were sent home very thrilled to have our first baby boy. For the first 2 to 4 weeks, I'd say things were pretty typical for a newborn. We were up a lot. You know, he cried a lot, but he was eating. We were just kind of adjusting to the new parent life. But around 4 weeks, we started noticing that Benjamin cried quite a bit. We could barely put him down. He seemed very uncomfortable. He had a lot of hypertonia in his lower extremities, which you expect a little bit in newborns, since they're coming from a very cramped environment. But he was not able to stretch out his legs at all, and his feet were very much like toes almost touching his shins almost all the time. And then around 6 weeks, I started noticing what very unexperienced. I haven't taken any classes, but what looked to me to be very stereotypical seizure-like symptoms. We immediately took him to our pediatrician. And I walked through our concerns about his hypertonia, about his excessive crying and discomfort. And I was fairly quickly dismissed. I was told, you know, you're a new mother. It's normal to be very anxious about various new mother type experiences. It's normal for babies to cry. The symptoms you're explaining are likely just reflux, and just kind of like very reassuring to me, which was good to hear from a pediatrician, but something in the back of my head was just kind of nagging me like, you know, this doesn't feel right. And in the car on the way home, I had my father drive me because I had been watching him in the car. I was concerned about him. And he had what was very clearly a seizure. His entire body locked up. He became very pale. His breathing was extremely irregular. And he was letting out these very rhythmic cries and shouts. So we redirected immediately to the emergency room. When we arrived, we were immediately admitted. They ran a whole host of different tests, trying to determine the cause of the seizures. They did witness a seizure almost immediately upon us arriving to the hospital. So they did say, yes, that's absolutely a seizure. We were admitted into the PICU for 5 days. And then I think we spent about 2 or 3 days on the regular floor after that. They ran all kinds of blood tests. They did a spinal tap. They did a CAT scan and an MRI. They did a 30-minute EEG. And at the end of this, they were able to get his seizures under control with Keppra. And they gave us the diagnosis of pediatric seizure disorder. We were told that the likelihood of him outgrowing it was very high, and that we should follow up with a neurologist and stick with his medication. So after we were discharged, we went home. We felt very relieved to hear that diagnosis. Obviously, no one wants to hear that their child was diagnosed with a seizure disorder, but it gave us some answers. It gave us some hope that this is something we could adapt to and move forward with. But it still felt off. Something was just still nagging in the back of our heads with some of the other unexplained symptoms that we were seeing in him, some of his, with the hypertonia. So we were still a little bit concerned. And then we were home for about 2 days. But Benjamin's seizures were coming more and more rapidly. After every single seizure, we would call in to his neurologist. And they would say, okay, well, let's up his Keppra dose. And so we did that 4 or 5 times. And each time we upped his dose, and each time he had another seizure within 4 hours. And they were coming more and more quickly and more severely. Finally, he was having uncontrolled seizures, and he was 6 weeks old. So we took him to another emergency room to get another opinion. That is when we were hospitalized for the second time. They took us in immediately, and things moved extremely rapidly from the minute we were admitted. They redid all of the testing that was previously done the past week, so that they could compare them all being done at the same time. With additional testing, they started him right away on a 24-hour EEG instead of a 30-minute one. And then we were immediately, we met with a neurometabolic doctor as well as a genetic doctor. And then we had specialist after specialist after specialist start filing in very rapidly. A lot of very intimidating diagnoses and symptoms were starting to be thrown at us. And as new parents, it was extremely overwhelming. They started mentioning that he had joint contractures, which explained the hypertonia. The ophthalmologist noticed some significant retinal changes within his eyes. The MRI showed calcification and low white matter in his brain. And they also diagnosed him with microcephaly and in a pretty severe form as well. From our perspective, it was extremely shocking to us having been diagnosed with the pediatric seizure disorder. We were thinking, maybe he needs better medication. But we had that underlying feeling that there was something more to this. So along with the shock and the panic was a little bit of comfort in knowing that we were being taken seriously and we were finally being heard, and that we were getting these answers quickly and we were going to be able to treat him quickly. Each doctor that came in was very, I would not say curt. They were very kind, but very frank. Being on a hospital floor is very different than meeting with doctors in the office. Everyone is extremely busy, understandably. So we would have a doctor come in and rapidly introduce themselves. They would check on Benjamin, and then we would hear these diagnoses, and then they were off to see the next patient. So all of these diagnoses were stacking up on us. And we started to wonder what is this? We'd never heard genetic diagnoses before being tossed into the mix. We started to wonder, was this something that happened during the pregnancy? Did we cause this? How did we get to this point? We felt a little bit like refugees in the second hospital visit. The first admission felt very rushed, and it felt like they were treating Benjamin's very obvious symptoms and then sent us on our way without looking into, what's the cause of this? What's the cause of this symptom, and how are we going to prevent it in the future? we didn't get a lot of in-depth answers. Whereas when we arrived for our second admission at Cincinnati Children's, the visit was extremely thorough, even though it was overwhelming. So though it was a little scary for us to have all of that thrown at us immediately, we were very grateful that these things were being noticed, because they were there regardless of whether or not we knew about them, and knowing about them was going to help us give Benjamin the best life possible and to treat any symptoms that were causing him pain. The one thing that we very much appreciated was that Benjamin's blood sample was sent in to do an exome mapping alongside of ours. And this small test initiated at 6 weeks old changed our course of life dramatically once we got the results. And without those results, I think we would have been struggling for quite a while to treat his symptoms and to really know how to appropriately support him. It took about 3 months to receive the diagnosis, which we expected. We were talked to quite thoroughly about, this is a very complex test. There's a lot of data that needs to be shuffled through to find the answers. We may not find an answer, but it's a good step in trying to find a diagnosis for Benjamin. I don't know. I think that this diagnosis was handled perfectly for us. We were updated via the phone, which was, I don't know how else you could do it per se, because if you called a family and told them that you had the diagnosis and then scheduled to meet them to give them the diagnosis, you have a family sitting for possibly days wondering what the diagnosis is. I think that wait would be agonizing. So we were told over the phone his diagnosis. The one thing that we did struggle with was our genetic counselor had told us about 2 months in that all of the quote unquote scary things had come back negative, which put us on, we felt a very false sense of relief thinking, this diagnosis, maybe it's something minor. And then when we did receive Benjamin's diagnosis, it was, I think, even more devastating because we were expecting something mild. When the counselor called us over the phone, excuse me. She diagnosed, or they had found results, abnormalities on his ERCC6 gene, which is the gene that represents Cockayne syndrome. We were told that it was life-limiting, that there were some symptoms that were fairly severe. We were told that it is a type of progeria. I vividly remember her requesting that we did not Google the condition before our meeting, which of course, I understand why they tell parents that, but every single parent is going to immediately Google their child's diagnosis. And the information that we saw on the internet was a very devastating. There were a lot of photos of children with very advanced Cockayne syndrome. That was the first thing that we saw, along with some very clinical explanations of Cockayne syndrome that were hard to read from the parent's perspective and not from a medical perspective. And looking back, we consider that phone call to be the beginning of what we call our anticipatory grieving process. So this was our acceptance that our child had a terminal diagnosis. This was the acceptance and understanding that he was going to have a very limited number of years with us. and that a lot of the things that we were expecting to be able to share with our child were likely not going to happen, that our life was going to be very, very different going forward from this diagnosis. However, receiving this diagnosis over the phone 2 days before meeting in person with our genetic counselor and the genetic doctor was very helpful for us. We were able to take some time to grieve and process the information, which I think allowed us to be more present in the meeting with our doctors and to have a list of questions to be more prepared. If we would have had that meeting and received the diagnosis in the office, I don't think that it would have been very beneficial for us at all. We would have been reeling from the diagnosis. We wouldn't be able to gather ourselves enough to even ask any questions or really process what we were being told. So to go over Cockayne syndrome a little bit, it's a very, very rare genetic condition, about 1 in 1 million. There are 3 different types of Cockayne syndrome based on 2 different genes. The ERCC6 gene is associated with type 1 and 2, depending on the severity. Type 1 is considered the typical CS. Children are generally diagnosed in childhood with a moderate progression. Type 2 is the most severe. It's diagnosed at birth or shortly after with rapid progression. And then type 3 is the least severe. Symptoms generally develop later in life, teens or adulthood, and the progression is much slower. It is a progeria-related type syndrome, so the DNA within the body can't repair itself normally, so that causes errors to build up within the body. And it has a very distinct phenotype. You can see sunken eyes, a large narrow nose. Most of the children are of very small stature, and there's a lot of noticeable eye changes. A lot of kids have cataracts or some pigmentations. They call it salt and pepper pigmentation on the retina, as well as optic nerve pallor. There's also a lot of abnormalities within the brain matter. You see a lot of string vessels and demyelination, which since it's a progressive disease, slowly gets worse. So kids struggle a lot with coordination. It's really a full body disease. Benjamin was diagnosed with a type 2, which was understood since he was about 6 weeks old when we started noticing the symptoms. Our face-to-face meeting, we attended the neurometabolic clinic. We met with our genetic doctor, our neurometabolic doctor, as well as a genetic counselor. Understandably, Cockayne syndrome had never been seen before at Cincinnati Children's. That did not stop our doctors from providing any little bit of information that they could possibly find on Cockayne syndrome. They answered all of our questions to the best of their ability. And one thing that we, at the time, were very frustrated with, but we are grateful for, is that they absolutely would not give us a prognosis. What we really wanted to know was how much time we were going to have with our son. And due to the unpredictability of Cockayne syndrome, that's not really something that a doctor can tell you. And it also is going to start a countdown in your mind. And I think it was very wise of them to not set some kind of arbitrary amount of time that we were going to have with our son, because it retrained us to focus on every single moment instead of, you know, he's a year old now. That's 1 year less out of the 3 that we're going to have with him. So it really helped us focus on being in the moment with our son and not focusing on, how much time we have left. And one thing that really sat with us for quite a while is them specifically saying, we don't know a lot about Cockayne syndrome, but Benjamin will be the absolute best cared for child with Cockayne syndrome. We will address all of his symptoms and he will live the best life that we can possibly give him. And we really appreciated hearing that instead of, a doom and gloom kind of diagnosis. I think it changed the meeting from something very sad to something hopeful and something very determined. It let us come up with a game plan instead of just soaking in that diagnosis and treating him as a terminal case. And another thing that they did is connected us to one of the very small communities of families that have children with Cockayne syndrome. And that helped us reach out to families that had also received the diagnosis. And that helped us a lot to have that small family of people that were experiencing the same thing. Here is a list of Benjamin's various doctors. As I had mentioned earlier, Cockayne syndrome affects the whole body. So we went through quite a few doctors. Obviously, he saw a genetic doctor as well as a neurometabolic doctor. He saw ophthalmology for, he had quite a bit of difficulty with his vision. We saw an ENT because he had difficulty breathing and swallowing. We saw an orthopedic doctor for his joint contractures. We saw dermatology because children with Cockayne syndrome are very, very sensitive to sunlight. We saw pulmonology because children with Cockayne syndrome get pneumonia very, very easily and suffer with a lot of respiratory issues. We saw GI constantly because he struggled a lot with his digestive tract, being able to absorb nutrients. And also he struggled quite a bit with nausea. Of course, we saw PT/OT and speech, nephrology and hepatology because of the medications he was on, put a lot of strain on his liver and kidneys. Urology due to bladder stones, audiology due to hearing loss, dental due to his microcephaly. That gives you a very small jaw as well. So you have a lot of dental issues. And then towards the end, we saw a TPN specialist when Benjamin could no longer digest anything. We switched to TPN, which really made a huge difference in his quality of life. And then, of course, hospice towards the end was one of the absolute best choices we made. We chose to enter the hospice program early because we wanted to put a large focus on Benjamin's quality of life over quantity. And hospice was able to help us make those kinds of decisions. They also were able to send nurses out to the home so that we didn't have to take him into the hospital as much. And they have all kinds of fun little programs like music therapy and art therapy that he absolutely loved. And I would say they were like a family to us for over a year. They were really amazing. In seeing so many doctors, we kind of sorted out what worked for us as a family and what did not. We looked for doctors that had a positive perspective on Benjamin's life and did not approach his diagnosis with a very defeative perspective. We looked for doctors that listened to us because Benjamin was quite the zebra and he had symptoms that were just really not expected to different treatments, different medications. And a lot of times we were overlooked as young parents. And so we had to find doctors that were a little more flexible in their treatments and that listened to us when we were trying to advocate for our son. And we tried to find doctors that focused on our outcome and not the diagnosis. There were doctors we would meet that would say, you know, that's just not possible because of his diagnosis. You know, he may never walk, or he may never crawl, or he won't be able to see well because of his diagnosis. And some of those things were true. Benjamin never walked, but we didn't want to be told that by a doctor. We didn't want to go into our expectations with our son saying, well, Benjamin, you're never going to walk, but we'll try other stuff. If he wanted to try that, then we were going to go for it. We were going to support wherever life took him. And so in meeting new doctors, if we picked up on that right away, we usually looked for someone who might be a better match, just because we wanted to focus on what we could do with Benjamin and what we could try, instead of just living out our days with Benjamin. And I like to take a little moment to talk about Benjamin as a little boy, and not just his diagnosis. He was such a sweet, happy boy, even when most of the time he was either in pain or having some kind of treatment. He was always so positive. I mean, he was always smiling. He loved cuddles. His favorite pastime was to be outside. He had a lot of vision difficulty, so he loved to lay under trees and see the silhouette of the leaves against the sky. He was also kind of a party boy. He loved lots of noise and excitement. Laser lights, twinkle lights, disco balls, we had it all. And cat toys, weirdly enough, anything crinkly or springy, bouncy. He was a blanket hog. He had maybe 20 blankets, the fluffier the better. And they were always on him. He would throw a fit if he didn't have some kind of blanket nearby at all times. He loved Elvis. I'm not sure why, but we almost always had Elvis playing for him. It was his absolute favorite. And he was just so strong, despite his limitations and his pain. He worked so hard in his therapies, and he soaked in any little bit of happiness that he could get from his day. And it was just amazing to watch. Coming from Benjamin's diagnosis, one of the first things my husband and I thought of is, we wanted to have multiple children. How do we approach this with our unique diagnosis and experience? We thought about it for quite a while, but we wanted to provide that sibling experience and that love for Benjamin. We wanted him to experience having a sibling and sharing life with them. We knew it would bring a lot of excitement and happiness to the home. We knew that he would absolutely love that. We knew that Benjamin's siblings would have this unique experience to learn empathy and acceptance. And we also felt that their lives would be greatly enriched by knowing Benjamin as their brother. Most importantly, we knew we wanted more children. And we didn't want to treat Benjamin's life like an event, like something we were waiting for to end before we moved on with our next step. And we felt that if we had waited until we had lost Benjamin, that it would be doing a disservice to the value of his life. And we knew that upon losing Benjamin, that we would need some purpose and some joy in our lives moving forward. Upon making our decision, we had to consider our various options. Cockayne syndrome is an autosomal recessive disease. So we had a 25% chance of conceiving another child with Cockayne syndrome. And we were uncomfortable discussing how we would handle a pregnancy that was diagnosed with Cockayne syndrome. Natural conception would naturally be cost effective. There would not be any medical intervention. Both parents would guaranteed be the biological parents. However, we felt that we would need to subject the pregnancy to testing to know if we were going to have a child with Cockayne syndrome. Our next option was to consider pre-implantation genetic diagnosis. So this is where we would have the embryos tested prior to implantation to see if they were diagnosed with Cockayne syndrome, and then implant only the healthy embryo for the pregnancy. This again, both parents would be biological parents. It would effectively eliminate the chance of having a child with Cockayne syndrome. The pregnancy itself then would not need to be subjected to testing. However, it can be extremely expensive. And there would be significant medical intervention prior to the pregnancy. And then we weren't sure how we would feel about having the excess embryos following the PGD. Another option we considered was adoption. The main con here was that adoption can take a considerable amount of time. And with Benjamin's very advanced case of Cockayne syndrome, time was really not on our side in this situation. Neither parent is the biological parent, which didn't bother us, but that would be the case. So the likelihood then of receiving a Cockayne syndrome diagnosis would be extremely low. But as mentioned in the previous PowerPoint, risk to families is heavily based upon previous experience, and having a child with Cockayne syndrome made us very sensitive to the thought that while it was extremely low risk to adopt a child with Cockayne syndrome, it wasn't zero. And that was unsettling to us. Obviously, there's no medical intervention when it comes to adoption. But again, there's potentially no genetic background or family history, which felt a bit like a Pandora's box to us because of our previous experiences. The next option we considered was using donor sperm or egg. This is a less expensive option compared to PGD. One parent would be the biological parent. There's a smaller amount of medical intervention. And then you would not have any testing during the pregnancy. And then there's no chance of having a child with Cockayne syndrome if you have the donor tested as well for the ERCC6 gene. However, unfortunately, there's still a bit of a social stigma with using a donor. So that was something we had to consider. Ultimately, we decided that this was the best route for us. We weren't particularly fazed by being biological parents. We went ahead with a sperm donor just because of the obvious simplicity of the process. We reached out and requested that our donor be specifically tested for Cockayne syndrome, which they accepted. So he did test negative. And we were surrounded by a very supportive community and had no concerns about social stigma. We've been very open with our process with our friends and family, and had decided prior to the conception of any children that we would be open with them as well and give them the option to, meet with the donor later if they felt like that was something they'd like to do. And then, of course, as I mentioned earlier, we went through preconception genetic testing again with the donor and requested that they, obviously donors are thoroughly screened prior to becoming donors. But unfortunately, Cockayne syndrome is so rare that it's not something that is normally tested for in routine screening. So we went ahead and had them specifically tested for Cockayne syndrome. And here you see the outcomes of said decision. We were surprised with two beautiful little girls. Natalie and Amelia. And we were blessed with a very straightforward pregnancy. They were both born very healthy. And Benjamin was absolutely smitten. He just loved them. He was our magical babysitter. Anytime they were fussy, we could lay them on his chest, and just his calm demeanor and breathing would immediately soothe them. And since he was always the fun one with crinkly toys and swings, he was immediately loved by his sisters. Benjamin's life with siblings was a bit chaotic, especially in the beginning. We were essentially having triplets. Benjamin physically and cognitively remained around 3 months old. So we would have all of our babies lined up in a row, taking turns doing medications and feeding them and loving them. A lot of times we just lay them all out on the floor and just have a big family cuddle pile because everybody loved cuddles so much. But it was really incredible because the things Benjamin loved were so age appropriate for them. So we could bring magic to the whole family at the same time with light shows and blanket excitement, and we had an absolute blast. Which brings us to the less fun topic at hand. Around when the girls were about 6 months old, we started noticing that Benjamin was really starting to show some more advanced symptoms. We were already in hospice, thankfully. So we were able to have a very frank conversation with our doctors and advocate strongly for focus on comfort. We slowed down his therapies to focus on comfort and followed his lead extensively, just depending on how he was feeling and what he wanted to do for the day. We did a lot of music therapy because it was his absolute favorite. We did our absolute best to minimize hospital stays because they were very stressful for him, and we knew that they were unlikely to change much unless he was in a significant amount of pain and we felt like something acute needed to be treated. We avoided any testing or anything that was going to require an overnight stay. And eventually we noticed that Benjamin was starting to tell us that he was ready. He didn't want to be held as much. He was less interested in his normal joys. He slept about 22 hours a day. He was in a lot of pain. And you could just tell that he was very tired, and not so much in the physical sense, but just spiritually tired. And that is when we made the decision to withdraw life support and let him pass at home. And so we were able to, both of us, be there with him and hold him under his favorite tree as he passed peacefully. Moving forward after his loss, we still work really hard to incorporate Benjamin into our daily life. The girls are 3.5 now, and we feel very mixed about the age that they lost Benjamin. They were almost a year old, and so they were young enough to avoid most of the grief of losing him. However, you know, they've slowly lost memory over time of the moments with him. So we are very cautious about maintaining a lot of stories. We tell them all kinds of stories about Benjamin. We keep the dialogue open. We answer any of the questions that they have, which are starting to get a little bit more detailed as they get older. Unfortunately, at 3.5, they have already had to understand the concept of death, and surprisingly have handled it much better than we expected. And so we have pictures all over the place of Benjamin. They call him Bubba, and they say goodnight to Bubba, and they have his bunny that they play with. And so we sometimes have some sad moments where they ask if he's going to come back, which are a little bit difficult to navigate. But I think overall, even when they were tiny, Benjamin had so many quiet moments with them, and they learned so quickly how to be gentle. Even at 6 months old, they were so gentle with him. And I think that Benjamin affected us as parents so dramatically that it has affected our daughters as well. Benjamin taught us not to worry about the little things. He taught us to live in the moment and just experience the little joys of daily life. And he taught us numerous times how to be patient and how to not set expectations on your children, and how to just enjoy every day, every learning step. And I think that's really affected the girls as well, because they are able to grow up knowing that everyone's different, that everybody grows and changes at their own rates, and that everyone is going through different challenges in life that you may not know about, and to be kind to everyone. And therefore, Benjamin has left us with quite a legacy. He affected absolutely everyone around him. I think he changed Anthony and I the most, of course, just broke us down to the building blocks of who we are and rebuilt us into someone we would have been without him. And then going out from there, he has affected every single person, every friend, every family member, even people at the grocery store who ask questions. He just kind of had this snowball effect on the people around us. That was just incredible to see. He inspired some of our friends to open a clothing line for children with special needs that allows access to certain ports and tubing, and has just, it still amazes me to this day, the difference that his little life made. We had him for 3.5 years, and it was like you took a lifetime of a human being and just concentrated it down to those 3.5 years. And he so inspired us that we bought 50 acres of land out in the country and built a house. And so did my parents on the same property. And we've taken this time to enjoy the little moments in our life and to cherish every single second that we have with our kids and with our family. And so he's just changed our lives completely. And that is all I have. I know it's a lot of information to dump on everyone, and it can be intimidating to ask questions, but please know that I'm completely open to answer anything, even if it feels like something that you wouldn't want to ask someone. I know that it can be a little bit emotional, so no worries.
I just want to say I have a son, Benjamin, who was watching all the pictures, and he was loving seeing your pictures. He's only 4, so he doesn't understand what's going on. But he was commenting how cute your Benjamin is the whole time, and that it's the same name as his.
Well, I'm pretty biased, but I think he is adorable. He kept that crazy head of hair his entire life. It was just gorgeous. I don't even know how he managed it, but he would just wake up and just have this like perfect swoosh of hair every day.
You're getting lots of thank yous in the chats, and I just wanted to say thank you so much for sharing Benjamin's story and your family's experience. It was really good to hear.
Thank you for allowing me to share. It always feels good to share Benjamin's story and just to have a few more people know about him and his life. So I appreciate it.
He's continuing to have an impact on all of these people who will be professionals and working with kids, and just appreciate so much you sharing and allowing us to learn from you and from him.
And that's something Anthony and I feel very passionate about, is having a genetic counselor made a huge difference in how we saw Benjamin's diagnosis and how we went forward. It made a lot of information very accessible to us, especially considering our future children. We never for once felt judged about asking some of the tougher questions. We were always given all the information that they had available. And I do feel that if we were to have access to a genetic counselor while we were inpatient, that it would have made a big difference on our experience. And just someone to sit down and tell us, this is not your fault. This is what a genetic diagnosis is. Let's walk through the diagnoses he has received so far, what they are, how we can handle it going forward, and just kind of helped us navigate that a little bit instead of being thrown into this chaos with a bunch of doctors who are looking to get answers, but are not particularly focused on the fallout that the parents are experiencing in between those snapshot visits while they're inpatient.
I do want to share that is now something a genetic counselor does. So we do now have genetic counselors on the inpatient side
That is
we
wonderful
didn't have.
to hear.
Yeah, so I'll pass along that to them, because I know they it's a newer role, and I think for the reasons that you stated is important.
I can only imagine how much of a difference that's going to make for the families going forward.
Are there any other questions? Well, thank you again, and thank you for extra time. I know we got behind a little bit, but appreciate it.